Two, one. Please start. We are live.
Good evening, everyone. I welcome you all for today's webinar on Oncology Insight Forum for Clinical Updates in Lung Cancer. With impulse pleasure, I would like to invite Dr. A.P. Dubey sir, who is Senior Consultant and Unit Head, Medical Oncology and Hematology, Metro Hospital, Delhi and Noida. For the welcome and introductory note, the stage is all yours, sir. Over to you, A.P. Dubey sir.
Okay, good evening, everyone, and thanks for joining this academic CME. And I'm so fortunate to have General B.N. Kapoor, who is my guide, teacher, and mentor. I would request sir to kickstart the session, sir.
Yeah.
B.N. Kapoor, sir.
Thank you, Dubey, for organizing this CME on clinical update in lung cancer. Lot of newer things are happening in, especially in lung cancer, and lot of new molecules have been identified which can be targeted by the new targetable therapies which are emerging in lung cancer. At one time, lung cancer used to be a dismal disease where the prognosis was very poor. But with the advent of these targetable therapies, the lung cancer malignancy now, I must say, it has become a chronic disease. It is not an acute problem, and people are surviving for many years now with this targetable therapies. To discuss all these things and the biomarkers which are responsible for the improvement in the treatment of the lung cancer. First of all, I would invite Dr. Sunil Pasricha, and he will be speaking on new biomarkers in the management of metastatic non-small cell lung cancer. Dr. Sunil, please.
Yeah. So good evening, everyone, sir. Thank you for your kind introduction. Okay, so can I share my slides?
Yes, sir.
Okay, so slides are moving.
Yes, sir. Yes, sir.
Yeah.
Okay, so I'll be talking about the new or the emerging biomarkers in advanced or metastatic NSCLC. So we know that more than 90% of the lung cancers, they are basically NSCLC, and out of which 50 to 60% comprises of adenocarcinoma. And the role of pathologist in this current era is not only just to diagnose a lung cancer, but also to find out the suitable targeted or the predictive biomarker so that the patients can be put on the targeted therapy. And why it is important? Because this is the survival of the patient with the driver in lung cancer mutation consortium when patient received targeted versus no targeted therapy. And you can see in this graph that when the patient received the targeted therapy, which is shown in orange graph, so there is a good prognostic separation of the curve as compared to when no targeted therapy was given or when no driver was identified. The consortium demonstrate that the best outcomes they are seen in the patients with identified drivers who are placed on targeted therapy with the approximately 3.5-year median survival. So majority of these common and uncommon driver mutations, they are targetable with the FDA approved agent or something which is on the clinical trial. So in the last 1 decade, we have seen a very unprecedented evolution of therapy in the lung cancer, and we have realized that it is not a single disease, but it's a heterogeneous disease. And so is the evolution of the biomarker testing, and it has been proven that it's a moving target. So until recently, we have mainly broad categories of the biomarkers. One is the minimum necessaries, that is the must-do test, which comprises of EGFR, L-cross, and PDL1 IHC. But then you have a recommended or the should-do test, like comprising of RET, MET, exon 14, HER2, KRAS, NTRK, and some others. So with the recent wealth of molecular information, it has also been realized that there are some potential application even in uncommon or some rare mutations as well. Because rarity can be just because from the epidemiology point of view, but for the patient, if it clicks, it matters a lot to the patient. So coming to the new or the emerging biomarkers, the most important is the exon 20 insertion mutation. So in the category of this EGFR mutations in NSCLC patients, approximately 10% of the patients, they have EGFR exon 20 insertion mutations, which occurs as in-frame insertion mutations in the EGFR kinase domain. The demographics are quite similar to that of the classical EGFR mutations, like they are seen in more commonly in the females, non-smoker. And perhaps they had a lower overall survival and progression-free survival than those with the common EGFR mutations, like EGFR del19 and EGFR L858R. So the most of the insertion mutations, they are seen actually in the C helix or the loop following the C helix, and the great majority they are seen between the codon 766 to 775 as shown in this photograph. But there is a one peculiar insertion mutation between the codon 763 to 764, and the peculiarity is that this insertion mutation still respond beautifully to the even the first generation EGFR TKIs, whereas all other EGFR insertion 20 variants identified till date have been found to be resistant to the early generation EGFR TKIs. This was the last study at the MSKCC, and it was actually around 6,290 patients with the NSCLC. So they found 2% they were having a EGFR exon insertion mutation. There were around 106 patients, while only 17% they had the EGFR del19 or L858R with MSK impact. So what they found that, as you can see in the graph A, that the exon 20 insertion mutations, they were having a significantly low tumor mutation burden as compared to del19 L858R, and also as compared with the cases when there was no exon 20 insertion mutation was found. And also these patients, as seen in the graph 2, that graph B, that the patients with the exon 20 insertion, they have a very high proportion of negative PDL1 patients. So this was the comparison of the overall survival and platinum-based chemotherapy, and when the patient was put on immune checkpoint inhibitor. So the dotted line is showing the EGFR exon 20 insertion patients, while the solid line is showing the NSCLC without targetable alteration. So we can see that the overall survival was comparatively better as compared to those who are having no targetable alteration. And the graph B is showing that the time to discontinuation of the treatment when the patient was put on the platinum-based therapy was slightly prolonged as compared to when there was no targetable alteration. But when these patients, they were put on the immune checkpoint inhibitor as shown in the graph C, the time to discontinuation of the treatment was shorter. Coming to the testing methods, so NGS is a recommended method because the heterogeneity of EGFR exon 20 insertion mutation is high, and the various studies have shown that a lot of exon 20 insertion mutations, they are missed on the PCR based assays. So the PCR technology has a very poor sensitivity and it is highly discouraged to detect these mutations. Two targeted therapies has been approved by the US FDA, that is the avimentumab and mobocertinib, and they are approved for locally advanced or metastatic NSCLC harboring exon 20 insertion mutations that has progressed after prior chemotherapy. But this was the recent the trial, the Papillon, the randomized phase 3 global study, which was the results were produced at the Madrid 2023 in October, and have shown the utility of amivantamab even in the first line along with the chemotherapy. So this was the study design of the phase 3 Papillon study. You can see that when the amivantamab was given along with the chemotherapy in the first line, so it reduced the risk of progression or death by 60%. The duration of response was also superior of the combination as compared to chemotherapy alone. Then there are some other uncommon EGFR mutations like exon 18 G719X, exon 20 S768I, or exon 21 L861Q. So this was a study that was published in JCO in which 37 patients with these type of mutations, they were enrolled and they demonstrated actually a favorable activity of osimertinib with the manageable toxicity used for those harboring these uncommon mutations. And this has been the largest cohort that has been studied till date, in which it was a multi-standard study comprising of 856 NSCLC cases with atypical EGFR mutations, including the co-occurring mutations that were reported from 12 centers. The data, the clinical follow-up data after treatment with different EGFR TKIs, chemotherapy, and immune checkpoint inhibitor, they were available from 260 patients. So the response to treatment, they were analyzed in the three major groups. The first was the uncommon mutations, these three mutations which I have just alluded in my 2 slides back. So they found that they had a higher efficacy of EGFR TKIs in comparison to chemotherapy. Regarding exon 20 insertion mutations, most of them, they were not EGFR TKI responsive. Then the third group was a very rare EGFR mutation. So the response rate to EGFR TKIs was highly heterogeneous because they were actually a very rare group. Coming to the next important target, that is the exon 14 skipping mutation, MET exon 14 and MET amplification. So it is also been considered as a dysregulation of the MET pathway. So MET is a proto-oncogene that encodes for the tyrosine receptor kinase for the ligand, the hepatocyte growth factor. So what happened here, you can see in this figure, like if the exon 14 is skipped during the messenger RNA transcript, so that leads to the formation of the truncated protein, which is of the Y1003, which is an important integral part of the TKI protein. So once this protein is abrogated, so it is not able to bind with the CCLB3, which is required for the ubiquitination. So if there is no ubiquitination, so that leads to a constitutive activation of the downstream pathway that leads to tumorigenesis. So what are the characteristics of the NSCLC with exon 14 skipping mutations? So they are seen in 3 to 4% of all the metastatic NSCLC. They can be associated with MET amplification as well and copy number variants. Often seen in females, elderly, non-smokers, and highly predictive of response to MET inhibitors. And it is also an independent indicator of the poor prognosis, which was established many years back. And you can see in the graph, the red line is showing the MET exon 14 skipping mutation having a poor prognosis. MET amplification is also regarded as a primary driver gene and one of the main mechanism of EGFR TKI resistance. And depending upon the assay and the positivity cut point used, the occurrence of the de novo MET amplification is seen in 1 to 6% in lung cancers. And many studies have associated the MET amplification also with the shorter overall survival. High amplification, that is the MET to the SEP7 ratio. So the ratio is also very important. It is the meaningful the ratio that is more than 5 or the MET gene copy number more than 10 that appears to be the strongest predictor of a true MET driven tumor, which is actually seen in 0.4% of the lung adenocarcinoma. MET amplification is also associated with poor survival in NSCLC patient as shown in this Kaplan-Meier survival curves. So based on the on these geometry trials, the capmatinib was approved by the FDA. So this capmatinib shows substantial anti-tumor activity in the patient with advanced NSCLC with the MET exon 14 skipping mutations, particularly in those who have not been previously treated. And the efficacy in MET amplified advanced NSCLC was higher in the tumors with a higher gene copy number than those with the lower gene copy number. Another drug, tepotinib, was also approved based on the encouraging results in the VISION trial, and the patient with advanced NSCLC with the confirmed MET exon 14 skipping mutation, the use of tepotinib was associated with a partial response in approximately half of the patients. So for detection of these, the RNA-based sequencing is now much preferred over the DNA-based NGS because the RNA sequencing has advantage of encompassing all the causal genomic events that leads to exon 14 skipping because it focuses more on the end result, the messenger RNA transcript. Hence, it is being more sensitive. And the RNA sequencing detects the fusion of exon 13 to 15. So in one study, approximately 60% of RNA positive results were found to be false negative in DNA assays. So this is how it is more sensitive. Like this is a normal messenger RNA, and you can see that it has an n number of base pairs. So exon 14 is there, but once exon 14 is skipped, it is not in the messenger RNA transcript. So you can see that the number of base pairs will be n minus 140. So this is a very objective criteria. Coming to the HER2 mutation. So HER2 is a EGFR family receptor tyrosine kinase seen in this HER2 mutation is seen in 2 to 4% of NSCLC tumors. It is more common in non-smokers and females. Majority of these are in-frame insertion in exon 20 and few cases show point mutation in exon 20. It has a worse overall survival than other subtypes in the lung cancer mutation consortium. And again, NGS is the recommended methodology. Early phase clinical trials suggest that the patient with these tumors harboring HER2 mutations who progressed on chemotherapy may respond to trastuzumab-based regime. Recently, FDA has granted accelerated approval to FAM trastuzumab deruxtecan for HER2 mutant NSCLC, and efficacy for accelerated approval was based on Destiny Lung 02 trial. And this was published in JCO in September 23, and they've concluded that the trastuzumab deruxtecan demonstrated a clinically meaningful response at both the dose, and the safety profile was acceptable and generally manageable, favoring the dose of 5.4 milligram per kg. Coming to the RET rearrangement, the RET gene encodes the cell surface tyrosine kinase receptor, and these rearrangements are identified in 1 to 2% of lung adenocarcinoma, often seen in young, never, or light smokers. And NGS is again the recommended method. Although break-apart fish can be used, but the single gene assay is not feasible and cost-effective. FDA has approved the two drugs, sulfasatinib and pralsatinib, for the metastatic RET fusion positive NSCLC. And based on the ARROW trial, the pralsetinib treatment produced the robust efficacy and was generally well tolerated in the treatment-naive patient with advanced RET fusion-positive NSCLC, and in the patient with the measurable intracranial metastasis, the intracranial response rate was around 70%. NTRK fusion, the NTRK1 gene encodes the tropomyosin-related kinase A. It has a prevalence of approximately 1%, and larotrectinib and trectinib are the two FDA-approved oral TRK inhibitor that has been approved in the tissue-agnostic fashion. Again, the recommended method is NGS, and the single gene testing method is the FISH. There is also this popular clone of immunohistochemistry which we are using in our lab at RGCI for last 3-4 years. Like this, but this antibody, which is the EPR 17341 clone, is recommended, but it is utilized only for the screening. If it is showing a strong positivity, then the patient can be subjected for the FISH or NGS for confirmation, just like we do for the ROS1 immunohistochemistry. Standalone tests are not cost-effective and feasible. Coming to the NRG1, which are also known as neuregulins, they constitute an integrate family of structural related cellular growth factors, including the NRG1 to NRG6. The fusion involving the NRG1 gene are rare, less than 1%. And these fusions, they cause the abnormal production of the epidermal growth factor-like domain of NRG on the cellular membrane that results in the pathological constitutive activation of the various downstream pathway leading to tumorigenesis. Prognosis of the patients with this NRG1 fusion protein is not promising, and they had a higher probability of extrathoracic metastasis and a larger tumor size. The prevailing literature have suggested a poor activity of chemotherapy and immunotherapy in the NRG1 fusion cancer. Recommended method again is the NGS, and the two drugs zenocutuzumab and saribanutuzumab have shown to be potentially beneficial for the NRG1 fusion cancer, and they act by inhibiting the receptor ERB2B3 heterodimerization. Very important, KRAS mutations. The activating KRAS mutations, which activate a number of downstream signaling pathways, they are observed in approximately 25% of lung adenocarcinoma. And in the category of these KRAS mutations, approximately half of them, they are having the particular point mutation, that is the G12C, where the glycine to cysteine mutations are there. And overall, in all, we can see that 13% of all the lung adenocarcinomas had this KRAS G12C mutation. Sotorasib is the approved drug by FDA for the KRAS G12C mutated locally advanced or metastatic NSCLC who have received at least one prior systemic therapy. Another drug, adagrasib, has shown encouraging results in phase 2 Crystal 1 trial among the 106 NSCLC who have been previously received the treatment. And additionally, adagrasib showed the therapeutic effect on NSCLC with intracranial metastasis as well. Again, the recommended methodology is the NGS. So optimizing the biomarker identification is very important, and now NGS is now much preferred over a single gene assay because a 10 nanogram input of DNA and RNA is quite sufficient. It is also a resource proficient. You have a one experiment, one platform. The variant allele detection cutoff, which is a very important parameter, is 5%. Hence, it overcomes the problem of low tumor fraction. It maximizes the detection of actionable and other driver mutation, and based upon the identified alterations, like if it is a tier 1, tier 2, or tier 3, subsequently the patient can receive the targeted therapy or can be recruited in the clinical trials. NGS has another important strength that it can use a plasma as a sample. However, the turnaround time is still a problem. So coming to the actionable biomarkers beyond the driver mutation. So molecular testing in advanced metastatic NSCLC is not limited to the search of the driver mutations only. Much attention has been given to identifying the markers that predict the response to immune checkpoint inhibitors as well. So as of now, till date, there is no robust biomarker as of now. These are the various biomarkers at our disposal, which we are all familiarized. And out of that, it is the PDL1 IHC testing, which has been established, a predictive biomarker for immune checkpoint inhibitor. Although not a very robust biomarker, but still the best we have. So coming to the biomarkers for the immunotherapy. So recent studies have shown that the co-mutation of KRAS G12C and TP53, it confers a good response to immune checkpoint inhibitor, as you can see in this particular row, which is showing the co-mutation of TP53 and KRAS G12C. The response to chemotherapy was poor and response to immunotherapy was superior. And also the mutation status of the KRAS along with the concomitant STK11 and KEAP1 mutation also leads to a diminished efficacy of the immune checkpoint inhibitor in lung cancer. So this was an important publication in JTO in 2022, and you can see that the two graphs on the left side, the graph A and C, which are showing a concomitant mutations of KRAS, and the graph A, it is showing in the graph A, if you see the red bar, this one. So here you can see when there is a concomitant mutation of STK11 along with the KRAS mutation, the response rate to immune checkpoint was very poor. Similarly, in the graph C, if you see the red bar here, when there is a concomitant KRAS mutation along with the KEAP1 mutation, again the response rate to immune checkpoint inhibitor was very poor. Hence, STK11 and KEAP1 mutations, they confer a worse outcome to immune checkpoint inhibitors among the patients with the KRAS mutation, but not among the KRAS wild type lung adenocarcinoma. So it's the concomitant mutations that leads to poor response to immunotherapy. And STK11 and KEAP1 mutation could potentially be predictive of worse outcome to both chemotherapy and immunotherapy. This is due to their pleiotropic effects on the cancer cell metabolism and immune system engagement. However, conversely, STK11 mutation does not seem to affect the efficacy of the KRAS G12C inhibition in the patients having KRAS G12C mutated NSCLC who are receiving sotorasib. So to conclude, there is an extensive role of biomarker testing in the metastatic or advanced NSCLC, and there is a potential application in uncommon mutations and new emerging biomarkers. The broad molecular testing NGS helps the investigator to identify additional unrecognized targetable mutations for the development of new highly specific targeted drugs. And it's incumbent upon pathologists to make the testing reliable by optimizing the pre-analytical, analytical, and the post-analytical steps. Thank you.
Thank you very much, Dr. Sunil. It was a very lucid talk, and you have covered very nicely the newer molecules, and probably in the future, a few of the molecules, the therapy is yet to be formalized and to be completely authenticated. But still, the newer molecular marker one has been identified, and the newer targetable therapy which has been identified will be quite promising in the future for the management of lung cancer. If anybody in the audience have any questions?
Yes, sir. Pachicha, sir, thank you. Thanks for such a beautiful talk on molecular markers. I just want to ask that at your setting, like whenever we ask for the lung NGS panel, so should we recommend, or we should even write in the bracket that both DNA as well as RNA based NGS, or everyone is doing both DNA and RNA based next generation sequencing first? And second, at your setting, are you doing this STK11 and KEAP1 mutations along with KRAS, or once KRAS is coming up as mutated, then you are going ahead with these markers to know the predictive value of immunotherapy in these patients?
Right. So it's a good question that you have raised. So basically, both DNA-based and RNA-based, they have their own strength. So if you are looking for a point mutation, it's a DNA-based, which is more robust. If you are looking for a rearrangement studies like, ALK, right? So for the rearrangement, it's the RNA-based NGS, which is most effective. So we have a very cost-effective panel at our institute. We have a smart lung panel, so in which it takes care of around 32 genes, and we are doing EGFR by PCR, and we are doing ALK by IHC along with the NGS, which is both DNA based and RNA based. So it takes care of both the point mutations, the copy number variations, as well as the rearrangements which are required to see in the lung cancer. And other thing that you have asked, though, there is no such in NGS, there is nothing like a step-based approach. So it's a comprehensive testing whenever you give the sample. So when the sample is submitted, so you get a comprehensive report, and it takes care of even of the mutations which are having a very low incidence.
Thank you, sir. Thank you, sir.
STK11, KEAP1, these mutations are also covered in the smart lung panel.
Sir. Thank you, sir.
Thank you.
Thank you, Dr. Sunil, for a very nice talk. And
Thank
then
you, sir.
we'll move on to the next talk. And next talk will be on the management of EGFR positive metastatic non-small cell lung cancer, the use of osimertinib, the real world experience. And I do invite Dr. Kaushik MR for the talk on osimertinib and metastatic EGFR positive metastatic non-small cell lung cancer. Dr. Kaushik, please.
So thank you, sir. So At the outset, I would like to thank Brigadier Kapoor sir and Dubey sir for the opportunity, sir. Nice to be in this platform with you people around, sir. So hope my screen is visible.
Yeah, it is visible.
Sir, kindly make it full screen, please.
Yeah, make it slightly.
Yeah. Thank you, sir. So, so my topic for the day is regarding the real-world experience of osimertinib in the management of the EGFR mutated non-small cell lung cancer. So we know based on the FLAURA data, we have a very good data which we have was available based for the osimertinib in the metastatic non-small cell lung cancer who are EGFR mutated, where we had achieved a median PFS of around 18.9 months compared to the first generation TK. It was seen to be around 10.2 months, and even the OS we had seen the Flora achieving OS benefit of approximately 38 months compared to 31 months in the first line EGFR TK compared to the when the osimertinib was used in these patients in the upfront setting. So it was around a landmark trial where a single AR medication which have given such a beautiful PFS and OS responses, and this was the snapshot of the Flora phase 3 data where the key inclusion were patients who had PS of 0, 1, majorly del 19 or L8 mutations with no previous therapies, and stable CNS metastasis were allowed in this Flora trial, and stratification was based on the mutation per se and also based on the race per se, and randomization 1:1 randomization to the standard of care. The first generation ticket was the comparator arm, and where the osimertinib was the trial arm, where the dose of 80 milligram per once a day dose was received. And again, the important was there was a crossover allowed after there was a progression or any progression or with any T790 mutation positive in those patients who had been progressed in osimertinib. Based on this, we achieved the primary endpoint of median PFS of 19.2 months in the osimertinib arm, and then next secondary endpoint was OS. It was OS was planned when there is approximately 318 deaths would have occurred. They had planned the secondary endpoint of overall survival, and when the analysis was done for the overall survival, it was seen at the data cutoff approximately with the 20. It was seen when around 22% of the patient who was on osimertinib or arm were still ongoing in the study compared to only 5% in the first generation TK arm when the OS analysis was done at the data cutoff point. So these were the baseline characteristics of the arm, quite comparable. Important thing you have to notice is the Asian subgroup had represented approximately 60%, and CNS metastasis, the stable CNS metastasis was to the tune of approximately 20%, and majorly everyone were in the PS0 or 1, and major mutations were exon del 19, it was to the tune of 60%, and L8 per mutation to the tune of 30 to 35%. There's a baseline in both the arms. So this was the primary analysis. The median PFS approximate to the tune of 18.9 months in the osimertinib. You can see such a beautiful separation of the curve starting from the initiation of the osimertinib compared to the first generation TK. So giving almost 8.5 months benefit with the use of osimertinib in the upfront setting compared to the first generation TK, and the benefit was seen across all the subgroups in this beautiful forest plot, whether it is either allied pet or del 19 or Asian or non-Asian. We can see almost the benefit is consistently seen throughout all the subgroup populations. And this was the OS data. Again, benefit was seen to the OS increasing from 31 months in the first generation TK arm to 38.7 months, almost around 8 months of benefit with the overall survival when using osimertinib in the first line setting. So this was a landmark data based on many patients. Our treatment changes, though the financial toxicity is an issue with osimertinib, but this was a one data which showed as very good improvement in those setting patients with which can avoid chemotherapy, and with the use of osimertinib had a meaningful improvement in the PFS and OS. So, and based on this, the NCCN had recommended upfront those who had not received any systemic therapy can be used either in the upfront setting, or who are on systemic therapy, they can be changed over to the osimertinib after completion of the systemic therapy, which remain the standard of care throughout even at present. So these are all the phase 3 data, and now can we extrapolate these phase 3 data to the real world setting? To see this or to justify this, we had few studies coming up in the base to look for the real world evidence of osimertinib. The major studies which we will will be discussing today is one is a flower study of the Italian from the group, and OCFAC study from the Japanese group, and Mykonos or the US group study. So first, the flower study. So this was the first line osimertinib in patients with EGFR mutated non-small cell lung cancer, and mainly the base was on the improved seen in the FLAURA data. It has been seen only approximately 2 to 3% of the patient would be those suitable patients which who are either enrolling in the real world RCTs. So it was to be seen is whether these data can be extrapolated in the real world settings. So they did this flower data in the Italian, almost 9 centers participated in this Italian study, and these were the key features. Again, here the baseline age was taken up to around 68 years, the median age, where in the flora it was up to the tune of only 60%, and brain metastasis was present in 30% of the population. In the flora, it was approximately to the around stable mets was seen in 20% of the population, and majorly had the PS. Another important was is the PS over here, like more than patient with more than PS2, even those patient with more than PS2, approximately 12% was included in the studies to see the differences. So these were the major inclusion and exclusion criteria. Almost remains the same as the Flora trial, and except for those more patient with more PS were also included those with other uncommon EGFR mutation. They didn't only restrict to do del19 or L8 Here they see that whatever the EGFR mutations are from the exon 18 to 21 are included in this flower study. So another important, the primary endpoint in this study was median time to treatment discontinuation. So in the real world setting, we even though there is a mild progression of the study subject on any therapy, we usually tend to use the same therapy for some time, because it is a common practice to continue treatment beyond the resist progression. We just don't strictly stop the therapy based on the resist progression. We look for the patient how he is tolerating the therapy, whether there is any clinical progression or not. So actually, this time to treatment discontinuation is the actual real world endpoint, which presently most of the trials are incorporating. So based on this was the primary endpoint which has been taken in this study, and also along that they just looked into the rate of treatment related adverse events with the use of osimertinib, and the rate of dose reduction or temporary treatment interruption seen because of the adverse events. The secondary endpoint in this study was the median overall survival, PFS, response rates, and disease control rate. Another important thing was diagnostic therapeutic pathway, which has been evaluated in this study to see the time frame between the diagnostic biopsy and the time to get the histological report. Also, the those patients who could have underwent the local regional treatment, and the frequency and the type of rebiopsy performed at the time of progression of the treatment. So, based on uh, this was the primary assessment, where the median time to treatment discontinuation. So in this study, it was seen that the time to treatment discontinuation median was to the tune of 25.3 months. Remember, the median PFS in the original Flora data was 18.9 months. Here, the median time to treatment discontinuation was 25.3 months, almost 6 months extra benefit in this real world data. So then they dissected it out to see whether there is any difference in patients with or without symptoms and diagnosis. At the time of data cutoff in this study, it was seen that those patients without any symptoms had not reached a median time to treatment discontinuation, and those with symptoms at the onset of that enrollment had a median time to treatment discontinuation of to the tune of 18.8 months. So almost fairly matching the Flora data, those with symptoms patients having a median time to treatment discontinuation of 18.8 months. Also, it was seen to the see how many those patients with number of metastatic, how they do with the medium this real world endpoint. So it has been seen there's even those patients with less than 3 metastatic sites. Again, in those subset also, the median time to treatment discontinuation was not reached at the time of data cutoff, and those with more than 3 metastatic sites, their time to treatment discontinuation was to the tune of 21.4 months. Again, more than what the median PFS achieved in the Flora data. Here it was 21.4 months with patients with more than 3 metastatic sites at presentations. So these were the issues with the Flora, because Flora had excluded patients with poor PS, patients with heavy comorbidities were excluded in the Flora, and rare EGFR mutations were not included. Also, active brain metastases were excluded. So here in this Flower study, we saw that the outcomes were similar, almost similar or much marginally better when compared to the original FLAURA data, and there was no difference in the PFS, time to treatment discontinuation, overall survival noted in elderly patients or patients with comorbidities or other uncommon EGFR or less common EGFR mutations as per this FLAURA data. So, and again, the important here was the time to treatment discontinuation, which was longer to the tune of 25.3 months in those compared to the FLAURA trial, and better TTD was associated with fewer than less 3 progressive sites, and also those patients with more than 3 metastatic cells also had a better TTD compared to the original FLAURA data. What they did, another important thing what was seen over here is based on the tumor burden. They saw that the patient with heavy tumor burden did fairly worse compared to those with a lesser tumor burden, mainly looking at the symptoms at present. Those patients with initially symptomatic patients, their PFS was on a lower side compared to those with symptomatic at presentation, and also patients with less metastatic sites and those with who didn't have any active brain metastasis, they did better compared to those with metastatic sites of more than 3 sites, or when there is an active brain metastasis present. So these were some stratification to see to choose the patient and to help them prognosticate the patient based on this multivariate OS analysis data. So at the median follow-up of around, coming to the effectiveness, here at a median follow-up around 12 months, it was seen that the median PFS was 18.9 months in the original data, and median OS was not at all approved. So here, was the median PFS, again, median PFS of original, it was 18.9 months, and here in those with brain metastasis, it was not reached, and those without the symptomatic brain met, it was around 13.3 months. And without symptoms, again, it was seen that those without symptoms, no PFS was, median PFS was not reached, and those with symptoms, the median PFS was to the tune of 15.5 months. Again, fairly, the result was seen, it was reciprocating the result which was seen in the FLAURA data. The same thing. So majorly what it was seen said also the important was to see the diagnostic and therapeutic pathway which was been seen in this data which they analyzed here. It was in around 47% patients after the progression they underwent a rebiopsy, and those 47% patients, almost 60 tissue biopsy was seen in 14 cases. It was total 21 cases which underwent a rebiopsy, and liquid biopsy was done in around 6 patients. So in those patients, the analysis, the molecular repeat NGS was done in approximately 13 samples, that was 60% of patients. The main reason for progression was here in this study was MET amplification associated with EGFR amplification, only EGFR amplification or HER2 amplification. So these were some of the resistant mechanisms seen in those patients who have been progressed post-data, which could help us in choosing the therapy and also looking for in our real world scenarios. So safety data, again, all grade adverse events was seen to the tune of 87%. With important is in those 87%, grade 1, grade 2 adverse event was only approximately 54%, and grade 3, grade 4 was 33%. Majority, what is important here, it is the ILD or the pneumonitis, which was seen in 7%, which was mainly grade 1, grade 2 manageable, and the diarrhea around 35% grade 1, grade 2, and the stomatitis. Important one, what it is seen apart from the major FLAURA trial was the venous thromboembolism. Here, 7% of the patient, approximately 7.9% of the patient had the venous thromboembolism and grade 3, grade 4 venous thromboembolism. This was almost against what it was seen in the FLAURA data, which was approximately 2% in those in FLAURA data. However, it was seen that even those with this 7.9% of the venous thromboembolism in these real world settings, there was no difference in the rate of VT as per the patient substratification compared to the age, comorbidities, or tumor load. It was not differ in those patients as per the univariate and multivariate analysis. So there was no difference in the survival outcome according to the age, comorbidities, or type of EGFR mutations. And this favorably confirmed the effectiveness of osimertinib in the real world setting. Next was the OSIFAC study, which it was the Japanese study here. Again, this they tried to evaluate the effectiveness in the real world setting to see, and the inclusions criteria remains almost same, and the exclusion criteria here again previously patient who had received as adjuvant treatment or those receiving in second level excluded standard exclusion criteria. Baseline was again standardly matched. Majority had PS of 192 in majority almost, but the inclusion you can see up to 4% had a PS3 also, were given osimertinib in the settings, and uncommon mutations was to the tune of 5.5%. Here was enrolled. All those with uncommon mutations were also taken part in this study. And another interesting was the PDL1 expression. Those with the more than 50% TPS was to the tune of 11%, and 1 to 49%. 30% and less than 1%, 30%. So this was the stratification used in the study to look for how those patients with PDL1 do with the use of osimertinib, and also with the metastasis, whether it can be leptomeningeal, pleural metastasis, or pericardial effusion, or the liver metastasis. These were the few of the substratification to see how the osimertinib fares better in these subset of populations. And the primary endpoint was a PFS as per the original trial, and the secondary endpoint was OS, the time to treatment failure, and the responses rates. Coming to the PFS data here, at the median PFS achieved in this study, OSIPAC study, was 20.5 months. And important parameters which actually affected the PFS in the study, as one is the male gender, we had a negative PFS compared to females, and malignant effusion. Those patients with malignant effusion did much fairly worse compared to the original one, and the liver metastasis in advanced unresectable cases. These were some parameters which were seen in this study were to be associated with a worse PFS. And with respect to PDL1 expression, which they had seen, the median PFS was not reached in those with the TPS score of less than 1%. However, with the TPS score of less than 49%, the median PFS was 14 months, and those with 50% of TPS, the median score was 11 months. So more the PDL1 score, the PFS was a bit on the lower side in this study. And based on the this was the same data what we're attaining, the male patients and the PDL1 did much lesser compared to the counterpart. Those with malignant pleural effusion or those with liver metastasis did fairly worse compared to this other counterpart. For treatment discontinuation profile, which was assessed in this data, it was seen the major reason for treatment discontinuation was disease progression in 44% of the patients, and followed by next in 25%, it was pneumonitis, which was majorly seen in this real world data, and followed by 16% in all other adverse events. Can it be diseases or cardiac failure or some QT prolongations, fatigue, anemia. So host of the factors which resulted to treatment discontinuation. So and fairly to the tune of around 14% in those with patient who could not be followed up because of the treatment discontinuation. So safety profile, which was the main highlight in the study, was the pneumonitis, which was seen in all grades of 12%, and almost the grade 4, grade less than grade 3 toxicity was to the tune of 4.5%. So that was the one of the flag point which was seen in the study when it was evaluated in the real world data. So the same one is the pneumonitis, another one was the non-hematological grade 3 toxicity to the tune of 11%. The rest all were almost as seen by the original trial with the safety profile. So overall, the study concluded that the overall response rate was to the tune of 76%, and the disease control rate was to the tune of 94%. The PFS was better in osimertinib than the conventional EGFR TKI, irrespective of the PD-L1 expression, with a median time to treatment failure of 19.1 months in this data, and medium time to start the treatment after the onset of adverse event over here, what they have seen in this data, it was to the range of approximately 2 months, that is 56 days, where the first adverse event was reported. And again, as we said, pneumonitis was all grades was seen in 12.88% of this patient, and grade 3 or higher was only seen in 4% of the patient. So overall, they said that PFS was matching in the real world practice as per the original trial, and the discontinuation rate, mainly because of the pneumonitis, was seen in 18%. Especially pneumonitis was major adverse event seen in this trial. So next, with the last one, we have the one real world data from the US setting, which is a
curtail this study.
Yeah. Yes, sir. Sir, just two slides, sir. Just two slides, sir. So this was the US data where they mainly took it from the electronic database and they observed it. So the data, the two endpoints what they taken was real world time to next treatment discontinuation or the time to treatment failure. So majorly the inclusion remains the same. Here it was seen that almost the analysis of the electronic database, what they have seen, around 58% remained in first-line therapy even at the interim analysis, and 18% of the patients who progressed, they received the subsequent therapy. This was the real-world time to next treatment was approximately 9.6 months, 17.9 months in this trial, almost fairly matching with the real-world population, the original data. Again, real-world time to treatment discontinuation was to that 17.2 months. These are all the surrogate PFS marker which was seen in this trial. Again, the factors which were negatively impacted was PS, mutation status, and the number of metastatic cells and liver metastasis. These were seen to be adversely affecting the trial outcome. So overall, the study provides the real-world insights into the use of first-line osimertinib in the patient with advanced EGFR non-small cell lung cancer based on the data, and the interim these results also support the effectiveness of osimertinib in the real-world studies compared to the RC phase 3 data. So these are the disclaimers, and these studies do emphasize the impact of osimertinib in the real-world data. We can be use it, and no much of adverse events. So almost our study data are matching with the FLORA trial. Thank you, sir. Sorry for exceeding the time.
Yeah. Thank you, Kaushik. You have extensively covered the real world data and the original study. And definitely, we all have used the osimertinib and we have found better results by the use of osimertinib. Cost do come in the way, but probably with the time it will also come down. And thank you very much for the very good stuff. Thank you. And now we'll move on to the next talk, and it is on the extensive disease small cell lung cancer and use of Tecentriq in extensive stage small cell lung cancer. I do invite Dr. Praveen Jain to discuss the talk on extensive disease small cell lung cancer, use of Tecentriq in the disease. Dr. Praveen, please.
So, good evening, sir. Thanks for the invitation. Yeah, 1 second. Let me share the screen. I hope my screen is visible.
Now it is visible. You can also make it slideshow also.
Okay. 1 second.
Yeah, it is there.
So, good evening, everyone. So, the talk which has been given to me is regarding the role of atezolizumab in first-line extensive small cell lung cancer. So, we were talking about non-small cell lung cancer, and we have really moved from non-small cell to small cell. So, non-small cell, which is like 50% of adenocarcinoma, so they are oncogene driven. And the small cell, where we were still struggling with the old chemotherapy regime since last 20 years, and there were nothing which was available to improve the outcomes. And I think on the basis of that, the small cell is a very immunogenic tumor, and with this rational immune checkpoint inhibitors and chemotherapy combination, they were tried, and atezolizumab was the first agent which was tried, and we will be discussing about it. And so this was the rationale for IMPAR 133, which was the registration trial for atezo chemo combination in extensive stage small cell lung cancer. And we know that small cell lung cancer, it was a very difficult to treat disease, and there was a dismal outcome despite having initial good responses. And in fact, we have seen complete responses with the chemotherapy alone at 3 cycles, and later on within next 2 months. So the patient is having a florid progression. So this kind of scenario everybody has seen in their clinical practice. And the 5-year overall survival rate with small cell when the chemotherapy was used was 2%. So it was close to negligible, and the median overall survival was 10 months. And with this background, so the goal, the immunotherapy combination, so they came into the picture. So and the rationale, I told you that because the microenvironment of small cell, so it is very immunogenic. And with this rationale, the chemoimmunotherapy combinations, they were tried. And this was the stage-wise overall survival rate of small cell with the chemotherapy alone. And we can see even in a stage 1A disease, so only 28% of the patients, so they were living for more than 5 years. And if we see at the other extreme, stage 4 disease, so less than 2% of the people, they were living with small cell for more than 5 years. So this was the dismal outcome which we were talking about, and this is the trial schema of IMPOWER 133. So they included those patients with measurable extensive stage small cell lung cancer with a good performance status. They included asymptomatic brain metastasis, but they also mandated that these brain metastases need to be treated prior to enrollment into the clinical trial. And they randomized these patients in two arms in 1:1 fashion. So one was the SOC arm, which was etoposide carboplatin. So here carboplatin was the only platinum which was chosen, and it was compared against a combination of chemotherapy along with atezolizumab. And these patients were randomized with a stratification factor of male versus female and ECOG PS of 0 versus 1, and those patients with brain metastasis or without brain metastasis. And the trial mandated treatment was 4 cycles of SOC or experimental induction therapy, followed by a maintenance atezolizumab in the experimental arm, and it was placebo in the SOC arm. And this was supposed to be continued till progression of disease or loss of clinical benefit. And the primary endpoint of this trial, so there were two endpoints. So this was a co-primary endpoint, which was overall survival and investigator-assessed progression-free survival. And the key secondary endpoints were objective response rate, duration of response, and the safety of the experimental regime. So this was the Kaplan-Meier curve, and this shows the initial interim analysis, overall survival analysis of this trial. And we can make out over here so that this trial met its co-primary endpoint. So one of the endpoint was overall survival, and it significantly improved the overall survival from 10.3 months in the SOC arm to 12.3 months in the experimental arm. And the hazard ratio for this was 0.7, which suggests that there was a 30% reduction in the risk of death in the atezo arm as compared to the placebo arm. And we can make out again that the curve, they started to separate before the median. So there was initial hugging of the curve, but later on these curves separated and they remain separated throughout. So this was the progression-free survival Kaplan-Meier curve, and we can see over here again the PFS was endpoint was also met. There was almost 1 month improvement in the median progression-free survival with a hazard ratio of 0.77, and it was also statistically significant. So this was the final overall survival analysis, which was published in 2020, and it was presented in ESMO 2019. And we can make out over here that the median overall survival was 12.3 months. But if we see at different time points, so 12-month OS rate, so it was 51.9% versus 39%. And if we look at the 18-month overall survival rate, so there was almost 34% of the people, or 1/3 of the patients, so they were still alive at 18 months. So this is something that the durability of response and the overall survival at different time points, which we have to see. So this is the crux of this trial. So atezo chemo versus chemo. So we can see that these the doses of chemotherapy, they were comparable. If we see the treatment related adverse events, so they were also comparable. Grade 3, grade 4, they were comparable. So the treatment related serious adverse events were also comparable, and the only difference was that there were more AEs leading to withdrawal from the trial. So, and probably because we are using an immune checkpoint inhibitor, so there will definitely be slight increase in the immune mediated adverse events. So the summary of the trial was that it was the first positive trial of immunotherapy chemotherapy combination. And atezo chemo combination, it had given the first line regime, which showed significantly and clinically meaningful improvement in overall survival and also in the progression-free survival, with no increase in the grade 3, grade 4 toxicities or the serious adverse events. and the superior survival benefit, it was demonstrated with a median overall survival of 12.3 month in the atezo arm and 10.3 month in the chemo alone arm. So coming to a recent analysis which was done, so it was the I-Umbrella A extension study. So it was basically an extension study of IMPOWER 133. We can see over here. So this is the IMPOWER 133 trial, so which we have already spoken about. And the last patient last visit was July 2020. And the updated overall survival analysis was done in January 2019. So between this period, so those patients who were still doing good or who were still alive and either they were receiving atezolizumab or they were on overall survival follow-up in the atezo arm. So those were given an option of rollover. So the rollover was something that this I-Umbrella A extension study. So this was a rollover study. And these patients were given the option to continue atezolizumab in I-Umbrella A trial. And so in total I-Umbrella A, so it included 18 patients. So it was a small study, but it gave a lot of information because this was the first trial which had given 5-year overall survival data for extensive stage small cell lung cancer. And out of these 18 patients, so 10 patients were the rollover patients and 8 patients were those patients who received atezolizumab and discontinued atezolizumab without progression in the IMPOWER 133 study. But they were on the survival update status. So whenever we do a trial, so there is a time period so where we are continuously looking for the overall survival. So these 8 patients were those patients. So in total, 18 patients were included. So if we see the baseline patient and disease characteristics, so we can see over here, so 5% of these patients, be it in IMPOWER 133 trial or I-Umbrella A analysis, so they were non-smokers, and almost 8% in 8.5% in IMPOWER 133 and 11% in I-Umbrella A. So they had brain metastasis, and 38% in IMPOWER and 11% in I-Umbrella, so they had liver metastasis. So looking at the long-term overall survival, again, so this is a similar curve. So because these are those patients who were there in IMPOWER 133, and the only thing is that this analysis has been conducted for more than 5 years. And so this is, we can say that the extension study of IMPOWER with a 5-year overall survival data for IMPOWER 133. So we can make out over here. So at 3 years, 16% of the patient, they were still alive in the atezo arm. At 4 years, 13% of the patient were still alive. And at 5 years, 12% of the patients were still alive. So practically these 16% of the patient, they got cured. So we can say in one way that they got cured of the disease, and they were the survivors of small cell lung cancer. And probably this has been achieved because of the atezolizumab, because in the placebo arm, if we look at, so 16% of patients were alive at 2 years, but after that there was no, the data was not there. So it was not estimable. So this is a swimmer plot of IMPOWER 133 patients who got enrolled into the I-Umbrella A trial. So this is the patient. So we can see what happened to those patients who got enrolled in the I-Umbrella A. So we can see over here that 3 patients, so they discontinued atezolizumab probably because of the disease progression. 4 patients, they died during the I-Umbrella A trial. And out of 18 patients, 11 patients, they are still alive and they are on study drug in I-Umbrella A. So this is something which is very important to look at, that yes, so that there will be only some patients who will get benefit out of atezolizumab, but yes, there is something called a long-term survivorship, which is also available in small cell lung cancer, at least for 10% of those patients who got enrolled into the atezo arm. So coming to the safety outcomes, because the trial, so this umbrella A, so it has an analysis of more than 5 years. So we can see that almost 100% of the patient, they had some adverse events. Almost 2/3 of the patient, they had grade 3, 4 adverse events, and only 2% of the patient, they had grade 5 events, and 40% of the patient, they had serious adverse events. And the serious adverse event which were noted in this trial, so out of these 18 patients, 3 had. So one was diarrhea, one was pneumonia, and one was procedural pneumothorax. So to conclude, so these data from IMPAR 133 and IMBRELA A, they provide the first report of 5-year survival outcome for patients who received first-line chemoimmunotherapy combination with atezo plus etoposide and carboplatin. The 5-year OS was 12%, and it was very much favorable as compared to the historical data of 2% 5-year overall survival. The long-term safety profile of atezo and chemo combination in umbrella A was encouraging, and there were no new safety signals which were noted in this particular trial. And these outcomes demonstrated the potential for durable survival benefit up to 5 years with atezo plus chemotherapy. Thank you.
Thanks, Dr. Praveen, for such a lucid explanation of the atezolizumab in extensive small cell lung cancer and also the extension of the trial. I just want to ask one question that do you have any experience of re-challenging the immunotherapy in patients who have responded very well to the immunotherapy in the first line,
Yes.
maybe in the later lines in extensive stage small cell lung cancer?
So there was one patient, she was 83-year-old lady. So she came to me with extensive stage small cell lung cancer, and the attendants, so they were very keen. So I told them that 83, we don't want to give a lot of chemotherapy. We can give some oral therapy. So because the performance status also was PS2-ish. So, but they were very keen, and they took some opinion from some other hospital, and they advised for atezo along with chemo. And on the basis of that, I started that patient on atezo chemo. So that patient took 4 cycles, I think, went into CR. So the performance status significantly improved. And one fine day, she had a fall and developed and sustained femur fracture. And after that, she discontinued the drug. And for 8 months, 10 months, then like she did not take any drug. And after these 8 to 10 months, she again came back to me. So she had slight bit of progression. And at that time, attendants, they again said that please go ahead with the treatment. She again took two cycles or 3 cycles of atezo chemo. And after that, again, she disappeared. Now she is coming on 3-monthly follow-up to me, and she is doing well.
Okay, without any therapy.
Without any therapy.
Okay.
So
great.
probably it is the biology of the disease which do the magic.
Okay. Thank you. Thanks, Dr. Praveen. So next, I would like to invite Dr. Group Captain Rahul Sood, who is a very kind colleague of mine, to speak on the topic which is sponsored by Astra, that is optimizing the decision in unresectable stage 3 non-small cell lung cancer. Dr. Rahul Sood.
Thank you, Dr. Dubey, for this opportunity. Good evening, one and all, and it's my pleasure to be speaking on my topic, which is on the lung cancer. And since the drug that is durvalumab, I'll be talking about the drug. Let's see how things go forward as we move into 2024. This is a drug which came up maybe about 2.5 years back, and we were very skeptical how to use this drug initially. And unfortunately, it came at the time when the COVID was also at its peak, and one of the complications of the drug was also known in the form of pneumonias. So let's talk about this drug, and I'll request if the screen can be shared for my presentation by Mr. Abhimanyu.
Technical team, kindly share the screen, please.
Yes, sir.
Yeah. Sorry, I'm just sitting in my car from my clinic, just came out. So I'll request if the screen can be shared, the presentation can be shared from your end.
Technical team, please do the needful.
Yeah, yeah. Thank you so much. I'll just request you to keep changing once I say. Uh, so my topic is regarding optimization treatment in stage 3 lung cancer, a stage where I think there is role for all, that is medical oncologists, surgical as well as radiation oncologists. So let me start with this case presentation. 59-year-old gentleman who had presented in July 2021 during the COVID times itself, with cough and weight loss for the past 3 months. He had no comorbidities, and this is the X-ray of the patient. As you can see, he's got a homogeneous opacity, which is involving the lung on the right side, upper lobe. It's a round, well demarcated opacity which is there, a lung mass which is there. Next slide, please. So on the CT scan, there was a well-defined mass measuring 5 into 5 centimeters. He had few lymph nodes, right paratracheal and right hilar region. Next slide, please. And also on PET scan, he had a posterior segment of the upper lobe which had a metabolically enhancing soft tissue density lesion. Mediastinal and hilar lymph nodes were there, and they were metabolically FDG avid. Next slide. So on histopathology, it came out to be a moderately differentiated adenocarcinoma of the lung. MRI did not show any brain lesions. As it is prudent in these days, we do the PDL1, we do the driver mutations. EGFR was negative, and PDL1 was positive with 20%. Next slide, please. So if we stage this patient as per the AJCC 8, the TNM comes as T3 because of the size of the lesion, the nodes present, N2 disease, and since there was no metastasis, M0. So it comes into that 3B kind of a disease which is there. And the 3B is, if we can say, a very, very gray area where probably the MDTC tumor board decides what to be done for the patient. Many times the surgeon may take this patient for upfront resection, and many times the patient may be taken up for a neoadjuvant therapy. So this is where we stood as the patient went. Next slide, please. So right lung NSCLC stage 3B, adenocarcinoma, PDL1 positive and EGFR negative, no other driver mutations. Next slide. So the treatment options were chemotherapy and radiotherapy. The surgeons did not basically want to get into this 3B, which is there. Even my surgeons go up to 3A. Concurrent versus sequential, which is better. Is there a role for induction chemotherapy, or is there a role for only definitive CCRT? And what is the role of consolidation therapy or maintenance in such a case? So these are the questions that needs to be answered in any patient who comes with a 3B disease. So let's go forward and discuss one at a time. Next slide, please. So the outcomes of definitive chemotherapy in an unresectable stage 3B. So these are the various studies which are there. Just give me a click once again, please. So what are the outcomes of definitive chemotherapy? So these are the various regimes which are there. And as you can see, majority of the regimes do provide some benefit as it goes. However, all these benefits that we get is not a sustained benefit in the absence of surgery. So therefore, majority of these patients will definitely relapse once the chemotherapy is stopped. Also, what we've also seen is the side effect profile in such patients of chemotherapy is also to be considered. Many of these patients are old, probably not able to tolerate the entire dose of chemotherapy. In there, it's the taxane plus platinum is the way to go forward in majority of our patients as we go forward. Next slide, please. So what about CCRT followed by sequential CTRT? Well, as you can see, the impact of 5-year survival rate with concurrent chemoradios significantly increased in the 5-year survival vis-a-vis the sequential. So it's a no-brainer that concurrent CCR chemoradiation is the way to go forward, and this has been shown in all these studies which is there. Next slide. So the question of sequential therapy is almost out. What about the effect of loco-regional relapse? When you give concurrent chemoradiation, significantly reduction in the risk of loco-regional relapse was seen with CCRT. So another place where the CCRT was is superior to the sequential therapy. Next slide, please. So patient in this case was initially given chemoradiation. He was started on that radiation through external beam IGRT, along with concurrent weekly paclitaxel carboplatin 4 cycles, and this is what the patient completed. Chemotherapy was stopped because patient had some liver dysfunction, raised SGPT. However, he did receive the entire dose of radiation as mentioned in the slide above. Next slide, please. So post the CCRT, this is the scan as you can see, and as you see that there is resolution of the initial lesion which was there. So there was a good response which was seen to the CCRT which was there. Also, the lymph nodes which were there have also reduced. In fact, they've almost regressed, as you can see. Next slide, please. So what about do we stop there, or is there a role of consolidation therapy? So majority of the studies so far have shown that consolidation therapy has not demonstrated any benefit in stage 3 patients. As you can see from the flowchart and also the table which is there, which is circled also, the role of consolidation in such patients does not usually happen. But many times we are tempted in continuing on consolidating with some form of therapy, but none of the studies have shown any benefit post CCRT. Next slide, please. So what do we do in such a case? Next slide, please. So these are the outcomes of various trials which were there. So we need to improve the outcome in unresectable stage 3 NSCLC. The biggest problem is CCRT gives a good response to these patients, but these patients have a tendency to recur either locally or metastasize after some time. So also by increasing the dose of radiation, I think we do not get the solution is not there. We would like to in 2024 try to bring down the dose of radiation as less as possible, and also the chemotherapy also in individuals who cannot tolerate. So immunotherapy, I think, is the way to go forward as a recognized safe and effective option as an adjunct to CCRT. So that probably is the way to go forward, and that is what we are now using. Next slide, please. So this is a Pacific trial, and it's a trial which came, like I mentioned before, the COVID trial, and somehow it took some time for this trial and the drug to probably percolate during the COVID. And this is the patients who were stage 3 locally advanced unresectable NSCLC, 18 years above, with good PS, estimated life expectancy more than 12 weeks, were randomized post CCRT into the durvalumab arm, 10 milligram per kg Q2 weekly for up to 12 months, vis-a-vis placebo as 2:1 randomization. The primary endpoint being overall survival and the progression-free survival, with a whole lot of other secondary endpoints. So what did the specific studies show us? Next slide. Next slide, please. Yeah. So the Pacific trial showed that there was. So this is the randomization, as you can see, 2:1 randomization, which is there, and I'll not harp too much into this. Next slide, please. Basically, both the groups were very well matched. It was a 2:1. Importantly, Pacific did not include EGFR mutated positive patients, because we know if patient has a driver mutation, they don't do well on an immune checkpoint inhibitor. Next slide, please. Yeah, so this is the updated 5-year overall survival, and this is what we were waiting for. As you can see, we had the data at 12 and 24 months when the Pacific trial was first launched, but now we have data till 5 years. And as you can see, even at 60 months, the overall survival is much superior, 42.9 versus 33.4 months. And this is statistically significant as we go forward. Just goes to show that the effect of immunotherapy even lingers on for a year or two, despite it being stopped post therapy. So as you can see, the graphs still separate at the end of 5 years, which is very, very heartening to see. Next slide, please. So the first and the only approved IO to demonstrate the overall survival benefit. Till date, there is no other. So this is the 5-year progression-free survival. Similar lines, there was a 33.1 versus 19.0 difference between the progression-free survival over a period of 5 years, which was there. Again, this was numerically as well as statistically significant as we go forward. Next slide, please. So the first, again, the only IO which has sustained and durable PFS of 33.1 month benefit at 5 years. No other IO till date has been approved in this line. Next slide, please. So this is the real world outcomes with durvalumab after chemoradiotherapy in patients with the unresected stage 3 NSCL. This is the Spotlight trial. A total of 332 patients who received durvalumab was analyzed. Approximately half of them who started durvalumab with the suggested period of within, because you need to start it within 42 days and of the CCRT. 40.5% received the drug for more than 11 months because we needed to give the patient for at least 12 months. So that means toxicity was acceptable, and the median follow-up was 17.5 months, which is there. And some of the patients were even basically followed up for 32 months. That is just short of 3 years. Next slide, please. So what did the real world evidence show? Next slide, please. So the endpoint and assessment again showed that the effectively include the TFST and the TTM is defined as time for durvalumab initiation until the start of the first subsequent anti-cancer therapy or drug, so either progression or death. And the other is the TTM, that is time from durvalumab initiation until the first date of metastasis or death. So this is what was studied in the Spotlight trial, and the exploratory endpoint was the progression-free survival as well as the overall survival, which was there. Next slide, please. So what did this real-world evidence show? And this is what we are mainly interested. So as you can see, there was absolutely no difference which was seen in both the arms, either in TTM or the TFST. Next slide, please. Also, the median PFS and the OFS was spot on when we compared to the Pacific trial. So therefore, the trial as well as the real world evidence went verbatim matched head to head. Next slide, please. Could you just change to the next slide? Yeah, so data from our retrospective or the observational studies are consistent with results of Pacific trial. So basically, this is the proof in the pudding. You do a study and you see the real world evidence. If they match, it really means that the drug works. So therefore, progression-free survival of 17.5 months, which was in alignment with Pacific trial. The overall survival, the TTM, TFST, though is immature. However, the initial studies have shown that they appear to be consistent with the Pacific trial. So there is definitely an overall survival, the time to metastasis and time to first treatment post-progression or death is also almost the same as the Pacific trial. So since Pacific trial was a positive trial, and it is one of the landmark trials, if I can say, the spotlight of the real world evidence supports the Pacific trial once again. Next slide, please. So this is the case. The patient was started on durvalumab therapy 42 days. Post 3 cycles were completed. A follow-up PET scan was done in this same patient. And what did we see in the PET scan? Next slide, please. So the PET scan basically showed that there was almost a complete resolution of the lesions which is there. If you see the lesions which are there on the top are the initial lesions, and the lesions below are the new lesions, are the PET. So there is almost a complete CR in this patient that is seen. Next slide, please. So there was a very good response. Hence, the patient continued to receive the therapy This is a chest X-ray of the patient. As you can see, the homogeneous opacity in the posterior aspect of the right upper lobe has totally gone. There are no evidence of even lymphadenopathy which was there. Next slide, please. So this is the follow-up PET, like I mentioned, which was done on 24/2/2022. And as you can see, there are a few lesions which have started appearing in this patient. So next slide, please. So patient continued to receive durvalumab for a patient of a total of 15 cycles. Patient came with complaints of chest pain, and this is the scan which was done when the patient came with the same, and the PET scan was done in this June 2022. Next slide, please. So it's almost been a year and a half, and as you can see, there are few lesions which are there in the right upper lobe, which is there, and few lymph nodes also appearing. Something below the diaphragm also. Next slide, please. So there has been a progression on the disease in the form of fresh lesions, lymph nodes, and there were lymph nodes in the abdomen. So what is the next step in the management? Well, this patient has received chemotherapy. Before that, he's received CCRT, and now he's received immunotherapy. So a patient has almost had a treatment for 2 years, and now what is the next line of treatment? So what do we do in such a patient? Well, I think the patient should go in for the next line of chemotherapy. Radiotherapy is out of the question. Whether you give immunotherapy post durvalumab, there is no data on that. Whether you challenge him with chemo radiotherapy, well, again, is not the way to go forward. Since the patient has fresh lesions and has metastasized below the diaphragm, I think the chemotherapy is the way to go forward. And that is what was done in this patient. Next slide, please. So this is the pattern of disease progression. Reduced rates of first progression was seen in durvalumab arm. However, intrathoracic progression was the most common with durvalumab in the subpopulation which was seen in any any study which was there. So remember that immunotherapy are not the tumorocidal agents; they are tumorostatic agents, and many times the tumor breaks out from these checkpoint inhibitors by mechanisms better known to the tumors itself. So this is the way. This is how it happens, and the progression usually starts in the chest again with lymph nodes and fresh opacities which are there. Next slide, please. Also, it is seen that areas which have been irradiated, these are the places which probably are not the places where the tumor will come. However, the adjoining areas are the ones where the tumor comes. So this is the pattern of disease progression, time to thoracic progression and to death. If you see the durvalumab in the placebo arm, it was 25.2 versus 9.2 months. So there was almost more than 3 times chances of developing intrathoracic progression with the placebo vis-a-vis the durvalumab. I am talking about the duration. Next slide, please. So the first subsequent therapy after discontinuation of durvalumab, in durvalumab, 41% of the patients and 54 patients in the placebo arm did progress. So systemic therapy administered with or without radiation therapy are the most common first subsequent anti-cancer therapy, which is then. These are the various things which are then. Usually the platinum doublet along with another agent is the way to go forward. Next slide. So this is the safety summary which is there, and I'll not harp too much on that. We all know about the safety of immunotherapies and what are the side effects which are there. Durvalumab is no different. So these are the side effects, the immune-related side effects which are there. Importantly, grade 3 side effects causing either discontinuation or probably death is very, very few. Next slide, please. So what are the take-home message? Stage 3B, well, MDT approach is the best. TCRT gives the best outcome rather than sequential therapy. Consolidation chemotherapy has no role. Importantly, these patients will relapse if you don't give them anything. So it's better that you continue these patients on immune checkpoint inhibitors. Durvalumab should be considered as a treatment option for all resectable patients of stage 3 who have not progressed on CTRT. Even individuals who had stable disease, in fact, did the best post with durvalumab. Durvalumab improves the outcome, all subgroups, irrespective of PDL1 status or EGFR status. Next slide, please. I think this is my last slide. Yeah. So as we know, it's the new standard of care. So this is the abbreviated prescriptions. I will not. Thank you so much. If there are any questions, I'd love to take it.
Thank you, Dr. Rahul, for giving such a beautiful presentation. I just want to ask one thing, that what is the time period you keep between the completion of chemo-RT and the initiation of durvalumab?
So realistically, if I tell you 42 days is not feasible in many patients, because post the CTRT, there are patients whose performance status are not very good. There are individuals who are very old. They also ask for more time for recovering from the CTRT, which they have also received. However, uh, our attempt is to at least start the drug within 2 months of stopping CTRT. So I think 60 days is where we fall in majority of the patients, which is there. Uh, I come from a government background where the drug is available without the cost. So the cost constraint is not there for the patient. However, availability is an issue which is definitely there when you demand a particular drug. Uh, so I think 42 days, maybe I'll say if 2 or 3 patients I've been able to start within 42 days. Majority of the patients maybe within 60 days. One of the patients I started almost after, you can say, with 3 months or so, because he had such profound neutropenia post the CTRT. He had radiation-induced toxicities which were there. I started him after 90 days. Though the data is very scanty, they say it's best to start within 42 days. But there are always administrative issues, patient issues, financial issues, which are always there. So I think
So I
that's
guess 8 to 10 weeks post CTRT is a good time
yeah,
to start.
yeah,
Right? Okay.
it's a
Thank
good
you.
time.
Yeah. Thank
Thank
you.
you so much.
Thank you.
Thank you.
Thanks a lot.
For the next session, I would like to invite Dr. A.P. Dubey, sir. This session is sponsored by Roche. Sir will talk about
Okay.
overview of T-centric in first-line metastatic NSCLC. Over to you, sir.
So, okay. Can you let me share the screen, please?
Yeah, sure, sir. Please share.
Yeah. So thanks, Abhimanyu, for the kind introduction. As my very good friend Dr. Praveen has already explained the role of atezolizumab in extensive small cell lung cancer, so I'll be talking about its role in non-small cell lung cancer. So these are my disclaimers. So understanding the molecular pathways which drive tumor, it has led to the improved outcomes in patients with actionable driver mutations. But the prognosis in metastatic and non-small cell lung cancer, where these are lacking any driver mutations, remains dismal. So their chemotherapy is the only option we have. But with the advent of immunotherapy, it has promised outcomes in patients who are lacking actionable driver mutations. So I'll be talking about atezolizumab, which is an immunotherapeutic drug, and its role either alone as a monotherapy or along with the chemotherapy plus minus bevacizumab. So these are the 3 trials which have addressed the role of atezolizumab either as a monotherapy or along with chemotherapy or chemotherapy plus minus bevacizumab. So I'll be discussing in brief about these 3 trials. The first is IMPAR 110, which has addressed the role of atezolizumab in metastatic or advanced non-squamous or squamous non-small lung cancer, which were PD-L1 selected, that was PD-L1 positive, and were negative for actionable targetable mutations, and where the primary endpoint was overall survival, and there were multiple secondary endpoints. Here, the patient was randomized either to atezolizumab or the chemotherapy based on the histology, and followed by the maintenance as per the response to the initial therapy. So these are the baseline characteristics which are relatively matching in all the arms with respect to the demographics as well as the tumor. So this trial was a positive one. It met its primary endpoint. You can see the overall survival is significantly increasing with the single agent atezolizumab in patients with high PD-L1 expression. And here you can see with the hazard ratio 0.59, that is means 41% reduced risk of progression or death. And also you can see the 12 months overall survival remains 64.9 in atezo monotherapy, whereas 50.6 in chemotherapy arm. So median overall survival, as you can see, was improved or increased by an awesome 7.1 months with atezolizumab over chemotherapy, and the median OS was 20.2 months. And also this the co-primary endpoint, progression-free survival, atezolizumab, though initially there was a fusion of Kaplan-Meier curve, but later we can see that the curves are separating, and the median progression-free survival with atezolizumab in patients with high PD-L1 expression is 8.2 months, vis-a-vis 5 months in chemotherapy arm, and with the hazard ratio of 0.59. Here also there's 41% reduced risk of progression or death with this atezo monotherapy. Also, this atezo monotherapy was improving the objective response rate in the patients with high PD-L1 expression. You can see that 40.2% objective response rate versus 28.6% in the chemotherapy arm. And one more thing, that this overall survival benefit in high PD-L1 expression patient tend to be consistent irrespective of the PD-L1 platform used for evaluating the PD-L1 expression. Now coming to the safety analysis, as we know that we are dealing with the metastatic disease where our intent remains prolongation of overall survival, but also maintaining the quality of life. Here you can see that the incidence of adverse events which were grade 3 and grade 4 were significantly higher in the chemo arm, but not in the atezo arm. Majority of the adverse event in atezo arm were grade 1 and grade 2, which were easily manageable as compared to the chemo arm where the grade 3-4 events were more than 50%. So to summarize, IMPAR 110, so it was a positive study because it has led to the significant improvement in overall survival as well as progression-free survival in high PD-L1 expression patient versus chemotherapy with a hazard ratio, beautiful hazard ratio of 0.59. And also the safety profile of atezolizumab was consistent with the prior whatever safety indication of whatever adverse effects it has shown in the previous trials. Now it is the second study, that is IMPAR 130 in non-squamous, means adeno large cell non-small cell lung cancer. Here the patients were patients with the stage 4 or advanced metastatic non-small cell lung cancer were randomized to atezo plus chemotherapy or chemotherapy alone. And these patients were in the first line, they were chemotherapy naive, and followed by, based on the response of the patient were put on maintenance either with atezo or the chemotherapy used pemetrexed. So the co-primary endpoints were PFS as well as overall survival. And why both chemotherapy as well as immunotherapy was used? Because as we know that chemotherapy kills the tumor cell, resulting in increased release of tumor antigens, and that should actually enhance or activate immune system. But due to expression of PD-L1 by tumor cells, which interact with the PD-1 on T cells, that result in downregulation of T cells or its priming. So that could be counteracted by immunotherapeutic drug which interact with PD-1 or PD-L1 and thus decrease or inhibit the interaction between PD-1 and PD-L1 and thus activate the immune system, and resulting in the increased trafficking of T cells in the tumor, infiltration of T cells, and recognition of these tumor cell antigens. So also one important thing or the unique thing, that nab-paclitaxel was used in these patients, because there are some anecdotal data that patients who are utilizing or are on steroids while on immunotherapy, there is a reduced efficacy. So the nab-paclitaxel is a steroid-sparing chemotherapeutic agent. So this was particularly used in this trial. So now you can see the demographic baseline characteristics, which are actually relatively balancing in between both atezo plus chemo as well as chemo arm with the respect of demographics as well as the tumor characteristics. Now, again, this trial was a positive trial. As you can see that the separation of Kaplan-Meier curves, it has resulted in significant improvement in median progression-free survival. As you can also see that the 12-month progression-free survival is 29.1% in atezo plus chemo, whereas 14.1 in chemo arm, and with a hazard ratio of 0.64, that is 36% reduced risk of progression and a significant p-value. Now, coming to this forest plot, here you can see that this atezo plus chemo, that's favoring almost all the subsets and all the clinically relevant subgroups. Also, coming to the second primary endpoint, that was overall survival, you can see the separation, though the separation is not that beautiful, but the separation is from the initiation of the atezolizumab till the end or till the follow-up is being made. Here you can see that the 1 and 2 year overall survival is significantly better in atezo plus chemo arm with the hazard ratio of 0.79 and a statistically significant p-value. And you can also see that clinically relevant subgroups are actually maintaining the OS benefit with the atezo plus chemo arm as compared to the chemo alone. Now, coming to the objective response rate as well as duration of response, that tends to be favorable in patient with atezo plus chemo. You can see that objective response rate, complete responses, partial responses are significantly higher in the patients who were receiving atezo plus chemo rather than chemo alone. Now, the safety summary, the addition of atezolizumab has not resulted in any increment in or any significant increment in any grade adverse event. You can see that the grade 3, 4 as well as grade 5 or grade 1, 2 or all cause adverse events are almost similar in both the arms. So it has not resulted in any significant increase in the safety signal. So this drug is safe to use to be combined with the chemotherapy. So this is IMPAR 130 was a positive study because it met its both the co-primary endpoint PFS in overall survival, which was statistically significantly improving as compared to the chemotherapy alone, and it has a very consistent safety profile as been shown or consistent with the prior trials. So this is the last trial which I'll be discussing, that is IMPAR 150. And this was also a phase 3 trial which has addressed the role of atezo with the chemotherapy plus bevacizumab, or chemotherapy plus bevacizumab alone. So here the patients with the advanced or metastatic small cell lung cancer, they were randomized to either of one arm A, which consisted of atezo plus chemo, arm B, atezo plus chemo plus bevacizumab, or arm C, chemo plus bevacizumab, and followed by, based on response, they were put on maintenance therapy. And if you talk about the co-primary endpoint, they were PFS and overall survival in intent to treat population. The baseline characteristics were balanced between the arms, but some unique things that has to be noted, that around 15% of the patient had extensive liver mets at the baseline, and 10% of the patient has actionable driver mutation, that EGFR mutations, and these were also balanced between these two arms. So generally immunotherapeutic drugs are not acting well, or the patient with actionable driver mutation are not deriving benefit from the patients with the tumors with the actionable driver mutations. So this again, this was a positive trial because it has met its primary endpoint of overall survival, that atezo plus bevacizumab plus chemo has resulted in significant improvement in overall survival, whether it is 12 months, 18 months, or 24 months, with a hazard ratio of 0.8. Thus, addition of atezo to bevacizumab and chemotherapy results in significant improvement in overall survival. Also, objective response rates and duration of response are significantly increasing in patients where atezo was added to bevacizumab plus chemo, irrespective of PD-L1 status, whether it was PD-L1 low or PD-L1 high, although the patients with the PD-L1 high are actually getting the maximal benefit. Now you can see that the patients with the PD-L1 high, they are also actually deriving the benefit from the addition of atezolizumab to bevacizumab plus chemotherapy. You can see the beautiful separation of the Kaplan-Meier curves with the median overall survival of 30 months vis-a-vis 15 months, means doubling of median overall survival in patient where the atezo was added to the bevacizumab and chemotherapy. And the OS benefit was consistent irrespective of the PD-L1 status, although the patient with PD-L1 positive tumors tend to derive the maximal benefit as compared to the PD-L1 negative. You can see that you can hardly see the separation of curves. They are almost overlapping. Now, efficacy in key subgroups. Now, the very important message given by this trial is that the patients who are having EGFR mutation or patient with external driver mutations, the addition of atezo plus bevacizumab plus chemo has resulted in improvement in the progression-free survival with a very beautiful hazard ratio of 0.59. And also it was seen that if these patients only atezo is added to the chemotherapy, it is not resulting in benefit. So the message conveyed is the best way to go ahead or go forward in these patients is to add both atezo plus bevacizumab along with chemotherapy once they are progressing on their targeted therapy or tyrosine kinase inhibitors. And you can see that the patients have very significant improvement in overall survival also with who are having actionable driver mutations EGFR with the and who have progressed from prior therapy, whereas if the patients have been added only the atezo to the chemotherapy arm, it has not resulted in any significant improvement. You can see the hazard ratio of 1.22. Now the patients who are where the atezo was added to chemotherapy plus bevacizumab, there is improvement in objective response rate and duration of response, that is 71% with the complete response of 6%, whereas 42 in chemotherapy plus bevacizumab with the complete response is only 0%. And also liver metastasis, there were 15% patients with extensive liver metastasis that is associated with poor prognosis. But here, what it has shown that these patients, the best way to go forward is to add atezo plus bevacizumab both. And that has resulted in significant improvement in progression-free survival, as you can see. And you can also see that there is improvement in median overall survival. But with just addition of atezo alone, there is no improvement in overall survival. So one should add both atezo and bevacizumab. But yes, the objective response rate and the duration of response are significantly improving with the addition of atezo plus bevacizumab with chemotherapy in patients with extensive liver mets. Also, the bulky disease that is also associated with the poor prognosis here, but it has shown that the patients who are receiving atezo plus bev plus chemo, they are associated with the better outcome as compared to the patient who are receiving only bev plus chemo or atezo plus chemo. Now coming to the safety profile, majority of the adverse event with the addition of atezolizumab was grade 1 and 2. Grade 3 and 5, there was no significant increment in the grade 3 to 5 adverse events with the addition of atezolizumab, and there were no new safety signals. They were consistent with the prior uh, safety data of the atezolizumab in the prior studies. So to summarize is that all these trials were the positive trials that atezo monotherapy in patients with high PD-L1 expression and atezo plus chemotherapy in non-squamous histology and with potential steroid sparing nab-paclitaxel, and patients who have progressed on tyrosine kinase inhibitor, patients who have extensive liver mets, patients who have extensive disease, they're the best way to go forward is atezo plus bev plus chemotherapy. So thank you. Thanks a lot. Thanks for patient hearing. I also take this opportunity to invite Dr. Megha, who will be speaking on the management of ALK positive metastatic non-small cell lung cancer, that alectinib versus lorlatinib. Dr. Megha, please.
Good evening, everyone. So I'll have to share my screen for it. So I'll be talking about lorlatinib versus alectinib in ALK-positive metastatic non-small cell lung cancer. So, coming to incidence of lung cancer, according to Globocan 2022, the incidence of lung cancer in India, it is the fourth most common cancer diagnosed, and the incidence of lung cancer with distant metastasis in males is 44%, whereas in females it is 47.6%. And the number of new cases in both the sexes from age 0 to 85 years in India is estimated to be around 120K in 2040 as compared to 72.5K in 2020. Coming to incidence of ALK mutation, so ALK gene rearrangement in lung adenocarcinomas is the second most common targetable genomic change after EGFR mutations, constituting 1.6 to 11.7% of non-small cell lung cancer. Now, what are the testing methodologies for ALK gene rearrangement? It includes FISH, IHC, sequencing, and real-time PCR. Now, differentiating FISH and IHC. FISH is fluorescent in situ hybridization. It uses fluorescent probes to detect gene and targets specific DNA sequences. Whereas IHC is immunohistochemistry, it uses antibodies to detect protein expression and it targets protein expression. FISH includes direct visualization under a fluorescent microscope, whereas IHC includes visualization of staining pattern under light microscope. The sensitivity and specificity for FISH is high as compared to IHC, for which it is moderate to high. FISH requires expertise in interpretation of fluorescent signals, whereas IHC requires expertise in interpretation of staining patterns. The turnaround time for FISH is longer as compared to IHC. Now, FISH is generally more expensive as compared to IHC, and it requires fresh or fixed tissue sections, whereas IHC can use formalin fixed paraffin embedded tissue sections. The sample preparation for FISH requires a DNA or RNA extraction and probe hybridization, whereas IHC uses tissue fixation and includes antibody incubation also. The automation potential for FISH is limited, whereas there is potential for automation in case of IHC staining process. FISH is widely used in molecular pathology and for detecting gene rearrangements, and IHC is also commonly used for detecting protein expression. Coming to multiplexing, FISH can detect multiple targets simultaneously, whereas IHC has limited ability to detect multiple targets. First-line treatment of ALK-positive non-small cell lung cancer. This image here shows the development timelines of ALK inhibitors. In 2007, EML4 ALK translocation was discovered, and in 2012, crizotinib, which is the first generation ALK inhibitor, was approved. The second generation ALK inhibitors, including ceritinib, alectinib, and brigatinib, were approved in 2015, 2017, and 2018, respectively. In 2017, the second generation ALK inhibitors, as mentioned, alectinib and ceritinib, they were approved for first-line use. In 2019, the third generation lorlatinib came into use and it was subsequently approved by US FDA for use in first line. Factors determining the choice of drug includes progression-free and overall survival benefit, brain metastasis, adverse events profile, and availability of subsequent line of therapy. Now a bit about ceritinib. It is a second generation oral tyrosine kinase inhibitor that inhibits both ALK and ROS1 rearrangements. The ASCENT-4 trial compared ceritinib with platinum-based chemotherapy. And as evidenced in this left Kaplan-Meier graph, the progression-free survival was much higher in case of ceritinib, which was around 16.6 months. And in chemotherapy arm, it was 8.1 months, with the hazard ratio being 0.55. And it was a significant result. And the right graph here shows the difference in overall survival between ceritinib and chemotherapy arm, with the hazard ratio being 0.73. Now, coming to alectinib, which is also a second generation oral tyrosine kinase inhibitor, it was compared with crizotinib, the first generation TKI in ALEX trial, and it was seen that the progression-free survival was much higher in case of alectinib compared to crizotinib, with the hazard ratio being 0.47. And during subgroup analysis, it was found that the alectinib was better as compared to crizotinib across all subgroups. Now, coming to cumulative incidence of CNS progression. So, in crizotinib arm, the cumulative incidence rate at 12 months was around 41.4%, whereas it was just 9.4% in case of alectinib. And the right graph here shows the difference in overall survival between crizotinib and alectinib, with the hazard ratio being 0.76. Coming to lorlatinib, which is a third generation oral tyrosine kinase inhibitor, inhibiting ALK1, ALK gene rearrangement. So the CROWN trial compared lorlatinib with crizotinib being first generation oral TKI. So the median progression-free survival was higher in case of lorlatinib, and the progression-free survival at 12 months was around 78% for lorlatinib and 39% for crizotinib. Here we can see that the graph is nicely separating between the two arms, lorlatinib and crizotinib, with the hazard ratio being 0.28 and the p-value being less than 0.001. Also, the survival without CNS progression was much higher in case of lorlatinib as compared to crizotinib. Coming to cumulative incidence of CNS progression as first event. So the cumulative incidence at 12 months was around 33.2% for crizotinib, and it was just 2.8% for lorlatinib arm, and the hazard ratio being 0.06. Now this graph here shows the difference in overall survival between the two arms, with the hazard ratio being 0.72. So this here summarizes the two trials, ALEX and CROWN. ALEX, which had compared alectinib with crizotinib, in the final analysis at 37.8 months, it was seen that the progression-free survival was around 34.8 months in case of alectinib, and it was around 10.9 months for crizotinib, and the hazard ratio was 0.43. And the CROWN trial, which had compared lorlatinib with crizotinib, at the second interim analysis, it was seen that the progression-free survival was much higher in case of lorlatinib, and the hazard ratio was 0.28. Comparing alectinib with lorlatinib, so the comparison should be done with caution due to heterogeneity in patient population and various other factors. So alectinib and lorlatinib, these both are ALK inhibitors, and both of them are approved in ALK-positive metastatic non-small cell lung cancer. Alectinib has limited efficacy against CNS metastasis, whereas lorlatinib has greater CNS penetration and it is much effective in case of CNS metastasis. Alectinib is metabolized primarily by CYP3A4 and CYP3A5 enzymes, and lorlatinib is also metabolized by CYP3A enzymes. Alectinib is given twice daily, whereas lorlatinib is given once daily. Common side effects of alectinib includes fatigue, peripheral edema, myalgia, constipation, whereas in lorlatinib, the side effects include edema and cognitive effects. Lorlatinib has poorer safety profile as compared to alectinib, which is generally considered to be safer. Coming to safety profile of ALK TKIs, so it has been seen in quite a few studies that dose interruption or reduction due to adverse events and also grade 3 to 4 adverse events were much higher in case of lorlatinib when compared to alectinib, whereas drug discontinuation due to adverse events was seen in 15% of cases in alectinib arm, and also pneumonitis was also seen in quite a few cases in 1.3% of cases in alectinib. Thank you, sir.
So thank you, Megha. So which drug would you prefer to start your patient with CNS metastasis, ALK positive lung cancer, and patient without CNS metastasis, ALK positive lung cancer?
So if the patient has CNS metastasis, then I would prefer lorlatinib as it has greater CNS penetration. And if there are no CNS metastasis, then we can go ahead with alectinib as it is much safer. It has a safer profile as compared to lorlatinib.
Fair. So thank you. So at the end, I would like to thank one and all, especially the speakers, uh, my respected teacher, Major General B.N. Kapoor sir, Dr. Rahul Sood, Dr. Kaushik, Dr. Praveen Jain, and Dr. Megha, and also each and everyone who has taken out their precious time to join this academic event. Thank you. And last but not the least, the organizing team to run it so smoothly. Thanks. Thanks to everyone.
Thank you everyone for joining the webinar. Thank you, sir.